Καταρχήν θέλω να ευχαριστήσω πάρα πολύ και τη Μαρία και τον Αλέξανδρο για τη μεγάλη προσπάθεια που έχουν καταβάλει και φέτος να οργανώσουν αυτή την ημερίδα. Εγώ θέλω να σας παρουσιάσω αυτή τη στιγμή τον προσκεκλημένο ομιλητή, τον ομιλητή ο οποίος θα δώσει την 7η ομιλία προς τιμή του αγαπητού συναδέλφου μας που χάθηκε, του Γρηγόρη του Γεωργαρίου. Είναι ο Θωμάς Πατριανάκος, ο οποίος είναι chairman στο Cook County, ένα μεγάλο νοσοκομείο στη Νέα Υόρκη, στο Σικάγο. Αυτοί είναι οι προηγούμενοι αποδέκτες. Βλέπουμε πολύ σημαντικά ονόματα της οφθαλμολογίας. Είναι τιμή μας που έχουμε το Θωμά φέτος μαζί μας. Ο Θωμάς ξεκίνησε με προπτυχιακές σπουδές στο Λαϊόλα, στο Σικάγο, συνέχισε στο Midwestern University, ιατρική. Έκανε το internship επίσης στο Σικάγο, όπου ήταν βραβεύτηκε ο κορυφαίος ειδικευόμενος ανάμεσα στους πρωτοετής. Συνέχισε ειδικότητα στο Cook County. Ακολούθησε συνέχεια υποεξειδίκευση στο Glaucoma, στο πολύ φημισμένο Mass Eye στη Βοστόνη. Και αυτή τη στιγμή επέστρεψε πάλι πίσω στο Cook County για να υπηρετήσει τους ασθενείς της νέας του πατρίδας πλέον. Και όπου διατελεί, είναι chairman του department. Αυτή τη στιγμή το Cook County είναι ένα νοσοκομείο στο οποίο είναι γνωστό κέντρο τραύματος, είναι νοσοκομείο στο οποίο έχει γίνει, αν δεν κάνω λάθος, η πρώτη μετάγγιση αίματος και είναι μέσα στα 30 κορυφαία ιδρύματα ειδικότητας στις Ηνωμένες Πολιτείες. Δεν θέλω να μιλήσω τόσο πολύ για τις δημοσιεύσεις του, για τη συνεισφορά του στη βιβλιογραφία. Αυτό το πράγμα που θέλω να σας αναφέρω είναι από προσωπική εμπειρία. Είναι ότι στη Βοστόνη ο Θωμάς κέρδισε την εμπιστοσύνη και τον σεβασμό αυτών των δύο γυναικών. Η πρώτη ήταν η Κάρολιν, η οποία ήταν διευθύντρια του Glaucoma του κλινικού κέντρου. Ήταν μια γυναίκα που στα 57 της χρόνια έτρωξε Ironman στις Ηνωμένες Πολιτείες, που είναι 2,5 χιλιόμετρα κολύμπη. Μάλιστα, κολύμπησε από το Αλκατράς πίσω προς το Σαν Φρανσίσκο. Στη συνέχεια κάνει κάποια χιλιόμετρα ποδήλατο και στη συνέχεια τρέχει ένα μαραθώνιο. Και η δεύτερη είναι η Τερέζα Τσένι, η οποία αυτή τη στιγμή είναι assistant professor στη Βοστόνη. Η Τερέζα ήταν τόσο προσεκτική, ανέφερε χαρακτηριστικά στα 15 χρόνια που ήταν στην κλινική πράξη, δεν είχε σπάσει ούτε ένα περιφάκιο και ήταν ικανή, μετά από 85 ασθενείς, να σου πει μετά από 15 ώρες εργασίας ότι ξέρεις, τον ασθενή νούμερο 32 δεν είδες μια συνέχεια στη γωνία στην τάδε ώρα. Έτσι, μιλάμε για γυναίκες αυτές τις λεπτομέρειες. Και όταν συνέχισα εγώ στη Βοστόνη, μου λέγανε με τα καλύτερα λόγια το Θωμά, αυτές οι πολύ ιδιαίτερες γυναίκες με τον πολύ ιδιαίτερο χαρακτήρα. Ο Θωμάς είναι ένας άνθρωπος ο οποίος είναι άνθρωπος αφοσιωμένος στο καθήκον, αφοσιωμένος στην οικογένεια. Έχει 3 παιδιά, είναι παντρεμένος με μία συνάδελφο ουρολόγο. Είναι αφοσιωμένος στο ρόλο του ως εκπαιδευτής, αφοσιωμένος στο ρόλο του ως αγαπητός συνάδελφος. Διατελεί ως μέρος της Planning Committee στο Glaucoma στην ACRS. Προέρχεται από μια οικογένεια η οποία είναι αφοσιωμένη στο καθήκον. Εδώ βλέπετε μια φωτογραφία με την ευρύτερη οικογένειά του. Ο πατέρας του, επίσης οφθαλμίατρος, έχει προσφέρει πάρα πολύ, όχι μόνο στην ελληνική, αλλά στην ευρύτερη κοινότητα του Σικάγο, βλέποντας πολλούς ασθενείς δωρεάν. Η μητέρα του δίδασκε επί 30 χρόνια στο ελληνικό σχολείο εκεί. Και πάνω απ' όλα είναι ένας αγαπητός φίλος και είναι μεγάλη τιμή μας που τον έχουμε φέτος να μας δώσει την 7η ομιλία προς τιμή του Γρηγόρη Γεωργαρίου. Θα ήθελα λοιπόν να τον χειροκροτήσουμε. Και μία επιπλέον σημαντική είναι ότι φέτος το Best of συμπίπτει με το Thanksgiving το αμερικάνικο, το οποίο είναι μια πολύ σημαντική εορτή και το Thanksgiving το πέρασε εδώ. Οπότε ένας λόγος παραπάνω. Θωμά, σε καλούμε στο βήμα. Ευχαριστούμε.
Σας ευχαριστώ για τη μεγάλη τιμή και ειδικά για τα ωραία λόγια που είπε ο Dr. Φιλιππόπουλος. Τώρα, για να μην σας κουράσω, θα ήθελα να αλλάξω στα αγγλικά, άμα μπορώ, για να συνεχίσω με το... θα μιλήσουμε σήμερα για new approaches in the management of glaucoma. So these are things that I want to talk about that you can take to work with you the next day. Okay, you can start using these things almost immediately. So the first word I want to concentrate on is this word legacy. In Greek, the word legacy translates to κληρονομιά. Okay, what it is the contributions that we make in life that leave an impression or a change even after we're gone. What other generations will remember us for, our lasting influence. In medicine, legacy is extremely important because it's what drives innovation, change, and progress. It's really the legacy of the leaders in our field that ends up helping to shape what it is and how we practice and take care of patients. So I want to take a little moment here to speak about the legacy of Γρηγόρη Γεωργαρίου. Γρηγόρη was born in Athens in 1962. When we talk about legacy, Gregori came from a family of ophthalmologists, so his grandfather and father were both ophthalmologists. In 1987, he went on to complete his medical degree in Rome with full honors. He then finished a PhD dissertation in the use of ultrasound to detect choroidal melanomas. From 1987 to 1996, he started as a young attending in the Vienna University Clinic and then the East Surrey Royal Eye Unit. In 1996, he decided to return back to Greece, where he succeeded in many endeavors, leaving behind a true legacy. He founded the Oasis Ophthalmology Center and also the Athens Vision Center. He helped develop intraocular lenses, pioneered the use of dropless cataract surgery, multifocal lenses, and bioptics. He also helped to establish many of the same-day ophthalmologic centers that are around today and in all of Europe. When I was asking people about Gregori, they said that he was a people person. He would sit down and have lunch at a taverna, and by the end of the time when he was finished, he would have 4 or 5 people that would want to have cataract surgery from him. But perhaps his most important legacy is the family that he left behind with his wife, Nano, and his 2 lovely kids, Peter and Helen. So let's move on with the actual presentation. So this is a slide on the traditional approach to glaucoma management. This is what, when I went on to do my glaucoma fellowship, this is what I thought I was getting myself into, right? This is how people practice glaucoma back 15, 16, 17 years ago. We would start off with a drop, then we'd go to another drop, then we'd do another drop. And then maybe we'd offer laser trabeculoplasty. And then there would be a long period of time where we wouldn't do anything at all, and we would slowly just see the disease progress before we offered a trabeculectomy, a tube shunt, and then finally a diode laser. So the question is, did this approach work well? And my answer is no. Why didn't it work well? Well, depending on what study you look at, both the SIGITS and EMGT study, 20 to 50% of patients with this approach still progressed. Because of our high reliance on medications, adherence continued to be a problem. And again, depending on what study you look at, anywhere from 20 to 90% of patients continue to have problems with compliance to medications. We all know the negative effects of medications. Hyperemia, ocular surface disease, which ends up decreasing quality of life for these patients. Chronic use of medications has been linked to failure of glaucoma filtration surgery later on. Prostaglandin use has been linked to decreased effect of laser trabeculoplasty. And also there's decrease in the effect of medications the longer you take the medications. And we also have to deal with the IOP fluctuations that occur with the peaks and troughs of medications. Finally, what about the complications? So if you look at the TVT study, 30% of patients undergoing trabeculectomy had failure versus 15% of those with tube shunts. And complications, 60% of those that had trabeculectomies versus 40% of tube shunts. So there has to be a better way. How can we treat patients with glaucoma in a better manner? The first is improving adherence, compliance, and quality of life. And this could be done through sustained release medications and also the early use of laser trabeculoplasty. One of the things that I really want to concentrate on is working early on to augment physiologic outflow. And that's important because if we're able to augment physiologic outflow early on, then we're going to get that conventional outflow system to continue to work and not to scar down, not to have those distal outflow channels scar down on us. Treating glaucoma earlier. And then finally, we want to treat glaucoma earlier and safer through the use of MIGS and even phacoemulsification, which was touched on early on. So the first thing I want to look at is sustained release medications and how we can use it to improve adherence, compliance, and quality of life. So sustained release medications have been shown to reduce the need to rely on patient compliance. It helps to decrease the topical side effects of medications. It helps to keep the conjunctiva healthy so that we have better outcomes later on if we decide to do glaucoma filtration surgery. And then it actually overcomes the natural barriers of the eye, which make it difficult for our topical medicines to actually get in and work. And then finally, they help to stabilize the pressure fluctuations that we see in medications. So this is a slide outlining the different forms of sustained release medication delivery systems that we have. You can see we have nanoparticles that are out there, microspheres. We have punctal plugs that we can actually put inside the punctum that release medication slowly. We have things that are placed on the ocular surface, like contact lenses that will release medications. Things that are placed in the conjunctival cul-de-sac, like little rings that can release medications. And then we have injectable medications that can be placed into the anterior chamber and release medication. The one that I want to talk about is something that I'm hopeful will be available to us in the US very soon, hopefully when I get back, and that's the travoprost implant, or the iDose. So the iDose is a 1.8 by 0.5 millimeter titanium implant that's anchored into the trabecular meshwork, and it releases a continuous release of travoprost. It has been shown to be replaceable. In phase 3 studies that looked at a 12-month outcome, there was a 33% reduction in intraocular pressure, and it was found to be non-inferior to timolol at all time points. At the end of the 12 months, 81% of these patients were drop-free. So here's a video of the implant actually being placed. Under gonioscopic view, you view the trabecular meshwork, and it's very similar to an eye stent. You place it into the trabecular meshwork, and you do a slight dimpling. You release the button. Once it's released, you want to shake it on one side, shake it on the other side, and then shake it in the middle to make sure it's nicely tucked in and it's not going anywhere. And then this is what it looks like at the end of the case. And I think that this could be a game changer in terms of the way that we treat glaucoma patients. Let's talk a little bit more about the study. So success, which was defined as an IOP that was controlled on the same or fewer medications, was found to be 93% at 12 months versus 67% in timolol patients. The timolol patients also had required 31% more medications. It also lasted longer than we thought. So in 72% of patients, the effect lasted for 24 months, and in 69% of patients, the effect lasted for up to 3 years. In terms of safety, there was minimal corneal endothelial cell loss. So this is a big thing that differs between the Durysta implant, where it was used basically for one dose because of endothelial cell loss. This can be repeatable. There was no periorbital fat atrophy noted in these patients versus 70% that's seen with topical prostaglandins. There was a very small rate of hyperemia versus the hyperemia rate of 30 to 50% with prostaglandins. And it could be administered in the office and in the operating room. The other study I wanted to touch on, and this really changed the way that I practiced medicine early on in glaucoma, is a light trial by Gus Gazzard and colleagues. So this study basically took patients with open-angle glaucoma and ocular hypertension, untreated, and randomized them into 2 treatment groups, either medication first or laser trabeculoplasty first. The medication group had started off with prostaglandins, followed by beta blockers, carbonic anhydrase inhibitors, alpha agonists, and if that didn't work, they would move on to a trabeculectomy. The SLT group was started with laser trabeculoplasty, followed by repeat laser trabeculoplasty. Then there was a rescue with medications, and if that didn't work, they would move on to a trabeculectomy. It went on for about 3 years, and the success for this study was defined as a 20 to 30% reduction from baseline IOP. So what were the results? Similar success rate between the 2 groups. 78% of the patients with a laser trabeculoplasty were medication-free versus 64% in the medication group. And then this was the big finding that I think changed a lot of people's minds, was that the SLT group required less glaucoma filtration surgery. There was less progression to actually depending on glaucoma filtration surgery. There was also less number of treatment escalations in the SLT group. It ended up being a lower overall cost, and the SLT was found to be safe and also repeatable. In a secondary analysis done by Wright and colleagues, an additional interesting fact was that the the groups that went through the medication group actually had a more rapid visual field progression than the patients that underwent the SLT. And in addition, the 6-year results, which were recently published, essentially mirror the same results as the 3-year results. All right, so I'd like to switch over to new drops. These are some new medications that are available. Latanoprost Bunode, otherwise known as Vyzulta, and Netarsadil, otherwise known as Ropressa. So they work in different mechanisms that our normal drops work in. So latanoprost basically enhances conventional outflow system through a nitric oxide donating moiety, which inhibits actin-myosin interaction and release of intracellular calcium, which leads to relaxation of the trabecular meshwork and increase in conventional outflow system. And then it also has a prostaglandin analog in there, which increases uveoscleral outflow. Netarsadil, on the other hand, is a Rho kinase inhibitor or a ROCK inhibitor, which enhances trabecular meshwork outflow, reduces episcleral venous pressure, and in animal models has been found to slightly decrease aqueous humor production. And then when you place it with the fixed dose combination medicine with the prostaglandin known as Rocklatan, it also enhances uveoscleral outflow. The most important thing that I want for you guys to remember out of this slide is that these medications both work by augmenting physiologic outflow, which I think is very, very important because the only medications that we had in ophthalmology, other than pilocarpine, which a lot of people don't use anymore, that actually augmented physiologic outflow was the prostaglandin analogs through uveoscleral outflow system, but nothing that actually that increased conventional outflow system. And the belief is, and my hope is, that by starting these patients early on these medications, that we may be able to lead to less scarring of the distal collector channels. Because we're helping them to work. We're not decreasing aqueous humor production and outflow. Let's look at some studies. So latanoprost Bunode, basically both the Voyager, the Apollo, and the Lunar study showed that they were more efficacious than latanoprost and timolol. The Jupiter trial showed that they were efficacious in Japanese patients with low baseline IOP. Okay, and this may be due to its effect of episcleral venous pressure. So this may be a medicine that may be useful in patients with low tension glaucoma. It can be considered, it had consistent efficacy throughout a 24-hour period of time, and it was found to be have a greater efficacy than timolol at night. And it had a very similar safety profile than prostaglandins, with maybe a slightly greater chance of hyperemia. What about Netarsadil? Phase 2 trials showed that the efficacy was similar to latanoprost throughout a 24-hour period. It also was found to be very good in patients with low baseline IOPs of 18 or less. In fact, it showed a 5 to 7 millimeter mercury decrease in IOP in those patients. And this may be may be useful in patients with low tension glaucoma. In the ROCKET study, it was found to be non-inferior to timolol. And then in the Mercury 1 and 2 study, the fixed dose combination of Netarsadil and latanoprost was found to be 1.5 to 3 millimeters of mercury superior in IOP reduction than compared to its individual components of Netarsadil and latanoprost. So a greater number of patients also achieved their target IOPs with the fixed dose combination, and it was stable throughout 12 months. So in terms of side effects with Netarsadil, very similar to prostaglandin analogs, maybe a higher chance of hyperemia. But this is something that's kind of specific to the use of Netarsadil, and this is cornea verticillata. And this is seen in about 20% of patients that use the medication. For the most part, it's not visually significant. I have seen patients where the pigment gets really dark and significant, and it does affect their visual acuity. But the nice thing is that you can stop it, and it is reversible. Okay, so we talked about this earlier too, which, by the way, I just want to mention that this is an extraordinary conference, and I've learned a lot just listening. It's very concise. The amount of information that's being delivered here in a short period of time is extraordinary, and I really give my hats off to everyone who's organized this. But I do want to talk a little bit about cataract extraction and glaucoma. So the first thing that I want to mention, and there's 3 key factors with cataract extraction and glaucoma. The first is that cataract plays a major role in the pathogenesis and the management of glaucoma, and I firmly believe that. Cataract extraction can help lower IOP in almost all types of glaucoma, and cataract extraction can and should be considered a possible treatment for glaucoma. Now, the question is, which factors, like how can we predict which patients will respond best with cataract extraction? How do we know which ones will have a best IOP lowering effect? The first thing that I like to look at is their preoperative IOPs. And this is true for all individuals. So normal individuals, patients with ocular hypertension, open angle, primary angle closure, and primary angle closure glaucoma, the higher the preoperative IOP, the greater the IOP reduction will be after cataract extraction. The next is the type of glaucoma. So patients with primary angle closure and primary angle closure glaucoma tend to have a better IOP lowering response than patients with regular open angle glaucoma. And patients with secondary open angle glaucoma, like exfoliation syndrome, tend to have more of an IOP spike an IOP drop than patients with primary open angle glaucoma. And finally, looking at things like the anterior chamber depth is very important, okay? Because the anterior chamber depth will tell you how much of an IOP response you'll have after cataract extraction for the most part. And it's inversely related to the post-op IOP. So patients with smaller anterior chamber depths tend to have a greater IOP reduction after you remove the cataract. Perhaps the study that showed this the most was the EAGLE study, which basically was a large multi-centered randomized control style looking at patients that had primary angle closure and primary angle closure glaucoma with pressures of greater than 30 millimeters of mercury. They were randomized into clear lens extraction and then LPI plus medications. And after 3 years, the clear lens extraction showed that patients that received the clear lens extraction had a better quality of life, lower intraocular pressures, less need for medications, a decreased need for surgery, and there was also an incremental cost effectiveness after you did the cataract extraction. So finally, I'd like to end things up with microinvasive glaucoma surgery. And this isn't the holy grail of glaucoma. It's not going to cure glaucoma by any chance, but it is something that is helping us to reshape the way that we handle glaucoma and the importance of tackling glaucoma early on when the disease is easier to treat, okay? So what does microinvasive glaucoma surgery do? It has a great safety profile, similar to cataract extraction, especially in more seasoned hands. It has a fast visual recovery. It can be offered earlier in the disease process. And again, this is where it's important to treat the glaucoma more aggressively when the disease is easier to treat, augmenting that physiologic outflow, not letting those distal collector channels get worse. Because of that, it can lead to better long-term outcomes. And it actually serves a place for us to bridge the gap between laser and traditional glaucoma filtration surgery. It helps to augment physiologic outflow, which keeps those distal outflows from scarring. It reduces IOP, but keep in mind that there is a floor effect because of it doesn't bypass the traditional filtration system. There's a floor effect of about 14 millimeters of mercury due to episcleral venous pressure. It also decreases the amount of medication. So these are one of the key findings that we see in all of these MIGS studies is that the reliance on medication, for the most part, after using MIGS does drop. You might not get that low intraocular pressure into the 12s and single digits, but the reliance on medications does change. And then it can be customizable to individual patients, and there's more options for us to treat our glaucoma patients. So again, I'm gonna go back to the slide that I started with in the beginning. This is the traditional approach to glaucoma management. This is what we have now. And it's extraordinary. The amount of things available to glaucoma specialists and to general ophthalmologists is just, it's mind-blowing. The best way that I would say that these should be split up is probably to the target area where they're actually being targeted. So there's subconjunctival MIGS, there's supraciliary MIGS, there's those that will drain into the ocular surface. There's ones that'll bypass the trabecular meshwork. There's ones that'll cut the trabecular meshwork. And then there's ones that affect actual aqueous humor production. So these are just some slides of different MIGs that we've done in the US that we've had some good results with. I know I don't want to I know I've gone over my time and I don't want to discuss any of these in particular, but I'd be happy to talk to anybody about any of the microinvasive glaucoma surgeries if interested. So in conclusion, you want to think about compliance, adherence, and quality of life. Our glaucoma patients shouldn't have to suffer anymore by taking medications that make their eyes red and irritated. And this can be done through sustained release medications, through early use of laser trabeculoplasty, and through the use of microinvasive glaucoma surgery. Remember to augment physiologic outflow. This promotes natural outflow and may lead to less scarring of the distal outflow channels. Limit the use of drops that work by decreasing aqueous humor production. Remember the use of ROCK inhibitors and nitrous oxide donating moieties. Cataract extraction being used early on is also important. Again, laser trabeculoplasty and microinvasive glaucoma surgery. Treat glaucoma aggressively and as early as possible when it's young, okay? Be reactive rather than proactive. Early glaucoma is always easier to treat than later on, like that one that we showed with the end-stage glaucoma, and you're like, okay, now I'm thinking about snuffing out. We don't want to deal with that. We want to try to catch it earlier on. And this can be done with MIGS through safer, customizable, and combined cataract extraction before they get to that end-stage disease. And then finally, trying and starting to view glaucoma as a surgical disease. And this is where the concept of interventional glaucoma comes into place, where sustained release medications are available, laser trabeculoplasty, cataract extraction, MIGS, and our traditional glaucoma filtration surgery. So I want to thank everyone for this honor again, and I hope that we can see you guys in Chicago next year for the American Academy of Ophthalmology. Thank you.
Λοιπόν, ευχαριστούμε πάρα πολύ τον κύριο Πατριανάκο για αυτή την εξαιρετική διάλεξη. Ακολουθεί η απονομή της τιμητικής πλακέτας στον κύριο Πατριανάκο από τον κύριο Κοψίνη.